Some research shows up to 1 million miscarriages a year in the United States alone. This would count as the third leading cause of death in America.
Wow.
Disease and cancer. There's so much effort and focus and attention to how can we prevent, the two leading causes of death. And there's absolutely no discussion or education on how we can work to prevent the third leading loss of life in the United States of America.
Hi there, this is Miriam Diallo, Communications Manager at APLOG, and I am not the host of today's episode. This is just a heads up that this is going to be another one of those episodes that has just too much good content for just one part. So this is going to be part one of a two-part conversation with our host, Dr. Susan Bain, and today's guest, Dr. Marguerite Duane, on the risk factors for and prevention of miscarriage. I hope you enjoy.
Welcome to Caring for Both, a curbside consult series by the American Association of Pro-Life Obstetricians and Gynecologists, APLOG. On this podcast, we bring on experts to provide insights to support you as a medical professional in your life-affirming medical practice and career. I'm your host for today, Dr. Susan Bain. I'm a board-certified obstetrician and gynecologist practicing in North Carolina, and I'm the vice chair for the APLOG board. So today I'm here with a guest you might remember from our first season 2 years ago, Dr. Marguerite Duane, a board-certified family physician. She is the co-founder and executive director of Facts About Fertility, an organization dedicated to educating medical professionals and students about the science supporting fertility awareness-based methods. She serves as an Adjunct Associate Professor at Georgetown University and as the Director of the Center for Fertility Awareness-Based Education and Research at Duquesne University College of Osteopathic Medicine. Dr. Duane cares for patients via direct primary care house calls-based practice, MD for Life. She served on the board of the American Academy of Family Physicians and the Family Medicine Education Consortium. So for those of you who are not aware, the recordings of our MBEC lectures, which Dr. Duane's actually going to be doing one of those for us, are going to be available online for enduring continuing medical education credits. So you can actually register today to view those talks once they become available, including Dr. Duane's, by basically going to conference.aplog.org. So this is a topic that will be difficult to summarize in a single conversation, so I really encourage our listeners to register to watch her full lecture. You will learn a lot and be in for a treat. So Dr. Duane, we're so happy to have you back on the show.
Thank you so much, Susan. It's great to be with you again.
Well, our longtime listeners might remember you from our first session, but for those new listeners that we have, we'd love for you to tell us a little bit more about the work that you're doing teaching restorative reproductive medicine at FACS and now at Duquesne University.
Thank you so much, for the opportunity. Yes, as you noted, I co-founded Facts About Fertility back in 2010 with a fellow family physician, and our mission is to educate the medical community, students, residents, midwives, doctors, about the science underlying how women can learn to track observable biomarkers of their cycle using modern natural or fertility awareness-based methods. There are a number of different natural methods that a woman or a couple can learn to use to better monitor their health, plan for their families, and work with physicians and other medical professionals like myself who are trained in the various natural or restorative reproductive methods. Personally, by way of disclosure, I am trained in multiple methods, including the Billings ovulation method, the Creighton model, FEM, which stands for Fertility Education and Medical Management, and Neo-Fertility. And with this training, we are able to use the female cycle chart as a diagnostic tool to aid in the diagnosis, treatment, and prevention of a wide range of medical conditions, including using it to help identify women who may be at risk of miscarriage. And the good news is there are medical organizations, including ACOG, the American College of Obstetricians and Gynecologists, and the American Academy of Pediatrics, that recognize that the menstrual cycle, or the ovarian menstrual cycle, as I like to refer to it, because ovulation is the main event, that the ovarian menstrual cycle really can serve as a fifth vital sign of health. So through FACS, we educate people through an elective that we offer through Georgetown University, as well as through online continuing medical education courses and conferences, such as the one we'll be hosting a month after the APLUG meeting. We'll be hosting a conference, New Horizons in Holistic Women's Healthcare, in Pittsburgh, Pennsylvania, at Duquesne University. And this is a new role for me now, serving as the director of the Center for Fertility Awareness Education and Research at Duquesne. It's a brand new center that was launched last July in 2024, at the same time that the medical school first opened. And it's one of the only centers of its kind in the United States, and in fact in the world, with a focus on using natural or fertility awareness-based methods to advance education.
Yeah, yeah. Well, thank you for filling in the gap and sometimes the lack of some really common sense methods that medical students and residents sometimes don't hear about. And then aren't comfortable sharing with patients. So I love that initiative at Duquesne.
And
So
it's funny
let's
because the
dive.
students, many of the students, when they take the elective through FACS, they're like, how come this isn't a part of our basic medical school curriculum? Like, this seems like fundamental, reproductive health and women's health information. And I'm like, yes, it really is. And it really
Yeah,
should be included. And FACS is really aiming to address that gap in knowledge from medical students from any medical school, and health professional students, whether nursing, midwifery, PAs, etc.
right. Well, it's basic physiology, and we take it our second year of med school, and sometimes it seems like then we forget about those root causes. So I'm glad to see that focus. So let's talk about miscarriage. And, to start off, I just want to make sure and remind everybody, because post-obs, there seems to have been in our profession forgetting what a miscarriage versus an induced abortion is. So what we're going to be focusing on today is the natural loss of a miscarriage compared to an intervention, which an induced abortion is, that has the intention of ending a pregnancy and not resulting in a live birth. So we're not talking about that today. We're talking about miscarriage. And so the first thing I'd love for you to do is just talk to us a little bit about pregnancy loss and the types or classifications of pregnancy loss.
Sure. Yeah, I'm happy to. And yes, it is really important that we use accurate terms. The term miscarriage is more of a colloquial term. I mean, the technical medical term is spontaneous abortion, but that does engender a lot of confusion, because then people conflate that with induced abortion, or termination of pregnancy, and they are different. With a miscarriage or an early pregnancy loss or spontaneous abortion, this is a result of factors, whether it's factors related to the embryo itself or factors related to the mother, that prevent the healthy development, or that prevent the development of a healthy pregnancy. And the way we classify early pregnancy loss and a natural early pregnancy loss, or again miscarriage, depends on when the pregnancy itself occurs. So, but in order to understand the timing, it's also important that we understand the timing of how we date pregnancies, right? So when you understand the basic physiology of the female reproductive cycle, there's often this perception that the cycle is 28 days long and women ovulate on day 14. That's the standard acceptance. Of course, the reality is that most cycles are not 28 days long, and most of the time ovulation does not occur on day 14, and yet that's what we do to determine the age of a pregnancy. And we date the pregnancy based on the first day of the last menstrual period, and then the first 2 weeks there is no pregnancy, because pregnancy doesn't occur until after conception occurs at the midpoint in the cycle, when ovulation occurs. But when we talk about pregnancies that a pregnancy loss before 5 weeks, we refer to this as a preclinical loss, or a pre-implantation loss. And this is the loss of an embryo within its first 3 weeks. Again, by dating it, maybe up to 5 weeks, but the embryo itself typically is less than 2 to 3 weeks um, in existence after fertilization. And with these losses, because they do occur so early, they are sometimes referred to as a chemical pregnancy. And I encourage my medical students to never, ever use the term chemical pregnancy, because it's not it's not a chemical. You have a developing embryo, but it may be referred to as a chemical pregnancy because the only way to detect it is through checking lab chemistries, right? Your quantities
Right.
of HCG. So, but when I explain to my students, using the term chemical pregnancy can be very um, damaging, and potentially traumatic to a woman who is experiencing the loss of an embryo at its earliest stages. But the best term to describe a pregnancy loss up to 5 weeks after the last menstrual period is to refer to it as a preclinical or a pre-implantation loss. Beginning at 5 weeks, which is typically the earliest we can identify the gestational sac on ultrasound, up until 20 weeks, we refer to this as is as a miscarriage. And again, the technical medical term is spontaneous abortion. Sometimes we refer to those losses up until 12 weeks gestation as an early pregnancy loss. Again, trying to use language that is not going to be as potentially harmful to the patient. So it's
Right.
really appropriate to refer to any loss up until 12 weeks, any natural loss, I should say, up until 12 weeks as an early pregnancy loss. From 13 to 20 weeks, that would be considered a late miscarriage. And then after 20 weeks, when if the pregnancy is lost, that's often referred to as a stillbirth, where the baby, the fully formed developing baby with, functioning organs, if the baby passes away after 20 weeks, we refer to this as a stillbirth.
Yeah, thanks for those classifications, and I really appreciate the emphasis on the meaning of how the words we use really matter with reproductive losses.
Yeah.
I recently did a talk, I think you did too, at Students for Life conference today after the March for Life, and my talk was actually called "Is Miscarriage Care an Abortion?" And it blew my mind that I even had to do the talk, but I know the post-ops chaos has led to that. But, we in medicine have used the terms, spontaneous abortion and threatened abortion, and always were able to separate those ourselves. But sometimes when our patients saw, like on discharge paperwork, the word abortion, they assumed induce. So I like the language that you're using because words do matter.
Really, I mean, I actually did a presentation a couple of years ago that was titled that Words Matter, the Importance of Accurate Language. And I think this raises another issue. I mean, as medical professionals, as physicians who care for women of reproductive age, we may encounter patients who experience miscarriage on a daily basis. So to us, it can become a very common event. And when things become common, it's easy to become more distant from it emotionally. But it's
Mm-hmm.
important. And I just want to acknowledge, I mean, for your listeners who have experienced a miscarriage, or for anybody who's had family members or friends that have experienced a miscarriage, and whether a woman has experienced her first miscarriage or her fourth or her eighth miscarriage, for that woman, it is that pregnancy, it is that loss. And it doesn't matter whether or not this was a planned for or desired for pregnancy, or if it was one that was unexpected, even, perhaps one where the woman was considering abortion. If she loses that pregnancy, it's a loss. And we need to pause in that moment and recognize the humanity and affirm the dignity in the loss for that woman, and really validate that, and give her the time and the place to mourn that. And it is important to know that people will react differently. For some it may be very traumatic, for some it may not seem to be as big a deal. I mean, it may depend on, again, the desire for the pregnancy, how far along the pregnancy is, but really just taking a moment and pausing and asking the woman and acknowledging, like, I'm so sorry for your loss. How are you?
Right. Yeah.
Hearing her,
Yeah.
because our culture, as you know, we encourage women to like keep their pregnancy a secret until they're 12 weeks. I mean, most OBGYNs or medical professionals that provide prenatal care won't even see women until they're 10 or 12 weeks along, because they're like, well, 15 to 20% of pregnancies are going to end in miscarriage, and the highest incidence of miscarriage occurs at 8 weeks. So we tell women, like, don't tell anybody. But if she doesn't tell anybody and she does experience a loss, then she
Right.
experiences that loss in isolation and in secrecy, and may not get the emotional and even physical support that she needs to manage that loss, and to process the trauma with the loss itself.
Yeah, that's a great reminder for all the healthcare professionals listening, just how the grief is real. It's different for all our patients. And while we may often see miscarriages, that's the only one they maybe have experienced, or, it may be multiple for them. So thank you for that reminder. When you think about and you teach about the causes of miscarriage, tell us a little bit more about why do people have miscarriages?
Yeah. I'm happy to, but before I do, I do want to touch a little bit on the incidence of miscarriage. I know I
Okay.
just said that, miscarriage happens about 15 to 20% of the time, and people that may seem like, oh, that's not a lot, 15 to 20%, one in six maybe. But I teach my students, when you look at the 15 to 20%, you have to ask yourself, what is this 15 to 20% of? What is the denominator? Like, what is the actual number of miscarriages, the actual number of embryos lost at their earliest stages? And the 15 to 20% reflects the 15 to 20% of all live births. And in the United States of America, the last year that we have data for live births is in 2022. And in 2022, there were 3.7 million live births. So 15 to 20% of 3.7 million is anywhere from 500,000 to 750,000 pregnancies that ended in miscarriage. That's
Right.
500,000 to 750,000 embryos lost at their earliest stages of life. And Susan, that based on human embryology, we know that the heart begins beating at about 18 to 21 days post fertilization, at about 5 weeks gestation, right? And so when the heart stops beating, between from 5 weeks on, you have the loss of a human life. And yet in the United States of America, we don't actually count miscarriage as a cause of death. It's not tracked as a vital statistic. And I know this may be a shocking statistic to people to hear, but if we did actually track miscarriage as a cause of death, 15 to 20% of all live births ending in miscarriage, 500,000 to 750,000, some research shows up to 1 million miscarriages a year in the United States alone. This would count as the third leading cause of death in America after
Wow.
disease and cancer. And it's February, it's Heart Disease Awareness Month. We're always
I've got my red on.
right. What are we doing to prevent heart disease? Cancer. What are we doing to prevent breast cancer and cervical cancer and colon cancer? There's so much effort and focus and attention to how can we prevent, the two leading causes of death. And there's absolutely no discussion or education on how we can work to prevent the third leading loss of life in the United States of America. So like I said, in the United States, it's, 500,000 to 750,000, perhaps up to 1 million. Worldwide, it's estimated that 23 million pregnancies end in miscarriage a year. And so how do we prevent it? This is where looking at the causes of miscarriage really makes a difference.
Okay, so those are pretty profound numbers when you explain them like that. Thank you for sharing that.
This has been part one of a two-part conversation between Dr. Susan Bain and Dr. Marguerite Duane on the risk factors for and prevention of miscarriage. I hope to see you again next week for part two of this conversation. Thank you guys so much.